Hello everyone, my name is Drew Arnold, and today I will be discussing an important and often challenging topic in psychiatric care, the use of seclusion. This practice, while sometimes viewed as a necessary intervention, raises significant ethical and clinical considerations that warrant careful examination. Seclusion, which is defined as the involuntary confinement of a person alone in a room or area from which they are physically prevented from leaving, is a practice used in psychiatric settings typically to manage acute agitation or aggression. While often implemented with the intention of ensuring safety for the patient and others, its use presents a significant ethical and clinical dilemma due to the potential for harm. My interest in this topic stems from my own experience in psychiatric nursing, where I've witnessed situations where seclusion felt like a necessary tool, but also some instances where I question its impact on the patient, particularly its potential to be re-traumatizing. This personal observation aligns with a broader national and international conversation about how we can best support individuals who are experiencing crisis. Nationally, the use of seclusion is closely monitored by regulatory bodies such as the Centers for Medicare and Medicaid Services, the Joint Commission, and various state agencies, with a strong emphasis on protecting patient rights and ensuring care is provided in the least restrictive environment possible. Despite this, variations in practice do exist, and the potential for misuse or overuse definitely remains a concern. Personally, as I've mentioned, I've seen how seclusion can deeply affect individuals. For patients, especially those with trauma histories, which is common in the populations I serve, like the children I've worked with, being isolated can feel punitive, exacerbate fear of abandonment, and ultimately hinder the therapeutic relationship that we're trying to build. This is why exploring this issue through an evidence-based lens is so important. It is important to acknowledge why seclusion is utilized. The primary rationale is to prevent imminent and serious harm to the patient or others when less restrictive interventions have been attempted and proven insufficient. In acute behavioral emergencies, it can be seen as a necessary tool to ensure the safety of everyone in the therapeutic milieu. It's intended to be a short-term, last resort measure to de-escalate a dangerous situation, providing a contained space until the patient regains control. Though rare, I have experienced crisis interactions where it definitely seemed like the only viable option to ensure everyone's safety. Despite its intended purpose, the potential for harm is significant. From the patient's perspective, seclusion can be a deeply distressing and even terrifying experience. It can evoke feelings of abandonment, fear, and hopelessness. As I noted earlier, and as supported by literature, for individuals with histories of trauma, the isolation inherent in seclusion can be re-traumatizing. The removal of human connection at a time of intense vulnerability and feelings of being out of control can be profoundly damaging to the therapeutic relationship and can feel punitive rather than supportive. The negative impacts of seclusion extend beyond the patient. For staff, implementing seclusion can lead to moral distress, feelings of failure, burnout, and even an increased risk of injury. There's also potential for vicarious trauma from witnessing patient distress. Systemically, reliance on seclusion can be resource intensive, requiring significant staff time for observation and management. It also raises questions about whether the focus shifts from therapeutic engagement to merely containment, and it consistently brings facilities under legal and ethical scrutiny. So, what are the solutions? A primary strategy is to enhance and prioritize de-escalation techniques. This involves skilled verbal and nonverbal communication, such as maintaining a calm tone and demeanor, using active listening and curiosity to understand the patient's distress, using radical acceptance and expressing empathy. Also, respecting personal space, helping patients identify their triggers, and early intervention are key. Crucially, a trauma-informed approach, which seeks to understand the why behind a behavior, is fundamental to effective de-escalation. Another vital set of solutions involves utilizing sensory and environmental interventions. Many individuals in acute distress benefit greatly from supports that help them modulate their sensory experiences. These can include access to designated sensory rooms, offering comfort kits with items like stress balls, soft blankets, or weighted items. Simple environmental adjustments like reducing harsh lighting or noise levels can also be incredibly effective. As Wright et al. Highlighted, sensory supports are a key alternative, and involving patients in creating their own safety plans, which might include these preferences, empowers them and promotes collaboration. Individual skills are essential, but sustainable change requires organizational commitment. This means comprehensive and ongoing staff trainings in de-escalation, trauma-informed care, and the effective use of alternatives to seclusion. Leadership must also champion policies aimed at reducing restrictive practices, such as the 6 core strategies to reduce seclusion and restraint as developed by the National Association of State Mental Health Program Directors. Also, implementing thorough debriefing processes for both patients and staff after an incident is crucial for learning and healing. Finally, diligent data monitoring helps track progress and identify areas needing further attention. Ultimately, many alternatives to seclusion are rooted in strengthening the therapeutic relationship. When patients feel heard, understood, and respected, the likelihood of extreme behavioral escalation decreases. This involves consistent empathetic communication, actively validating their feelings even when their behavior is challenging, and working collaboratively to solve problems. Sometimes the simple therapeutic use of presence, which is just being with someone in their distress without judgment, can be more powerful than any physical intervention. Exploring this issue has reinforced my belief that while safety is paramount, our approach to achieving it must be deeply rooted in compassion and an understanding of the potential harm of restrictive practices. The literature strongly supports a shift towards preventative, trauma-informed, and patient-centered strategies. As nurses, we are the forefront of patient care and are uniquely positioned to advocate for and implement these changes. It's about cultivating environments where patients feel truly safe, respected, and supported in their journeys, minimizing the need for practices like seclusion. So, in summary, the use of seclusion in psychiatric settings is a complex issue. While intended for safety in acute crises, it carries significant risks of psychological harm, potentially re-traumatizing patients and damaging the vital therapeutic relationship. Fortunately, evidence-based solutions are available and effective. By prioritizing comprehensive de-escalation training, utilizing sensory and environmental supports, fostering strong therapeutic relationships, and ensuring organizational commitment to culture change, we can significantly reduce our reliance on seclusion and create environments that are truly safe and conducive to healing.